As a result of these, it was recommended that antibiotic prophylaxis for smaller surgical procedures, dental procedures, must be followed in all these patients. What is most important is that patient education is critical in the management of pulmonary arteriovenous malformations. You must understand that you are not going to eliminate all small malformations. These will develop, new lesions will develop over time, these will increase over time. So patient must be educated on the risks of complications developing from asymptomatic malformations and the importance of careful, close follow-up after treatment, after embolization for disease. Now, how do we follow up? What we do at AIIMS is that we do arterial blood gases at 1 month after successful treatment and then at 1 year after embolotherapy. We do not do routinely CT angiographies. We would probably do one CT angiography every 2 to 3 years, but would follow them on chest radiography alone to see for increasing size of the malformation. If significant hypoxemia remains after embolization or develops in the period after embolization, it usually suggests recanalization of the lesion and treat it as such. This shows you the experience. Actually, about 16% of patients after successful treatment have developed or have had persistent arteriovenous malformation, which was responsible for the recurrence of hypoxemia. And the literature rate is also approximately the same. 10 to 14% of these patients after successful treatment will develop recanalization over time. Now, why do recurrence develop? Recurrence develops because of two reasons. There can be recanalization, that is one reason, or there can be interval growth of the accessory vessels leading to the malformation. That can be the second reason. Recanalization is far more common. As you can see, majority of the patients who have a recurrence actually have a recanalization of a previously treated lesion, and this happens because you chose the wrong device. Either you chose a very big coil or you landed the coil very proximally. These are the two critical issues need to be addressed at the time of device selection for embolization. If you are using vascular plugs, all these issues can be eliminated at the beginning of the procedure. Now, just a word about the surgical management. Should surgery be performed at all in the patients with pulmonary arteriovenous malformations? There are clear situations, like embolization did not succeed, like the lesion was not suitable for embolization, like despite embolization, the lesion ruptured and produced a bleeding complication. Intrapleural rupture, that's another problem. These malformations are frequently intrapleural. In these situations, surgery can still be done. Usually when surgery is done, it should be conservative surgery. It should be lung conservative surgery. Now, what are the outcomes of surgery? As you can see, all the surgical literature which I reviewed for your benefit has a 0% mortality after pulmonary arteriovenous malformation surgery. So you have to understand the risks of embolization have to match those of surgery if embolization has to remain in contention, viable alternative for the management of arteriovenous malformation. Post-operative follow-up shows that recurrence rates are almost the same as they are after endovascular treatment. So clearly, surgery is a viable option. Surgery is a good option in suitable patients. So how should I conclude? What I would say is that these are distinctly rare, usually congenital lesions, but tuberculosis should be remembered as a secondary cause of pulmonary arteriovenous malformation. In our setting, I have seen about 6 patients of pulmonary arteriovenous malformation developing in a given patient of pulmonary tuberculosis. So this is an important thing which you should remember. Usually when they are multiple, they are associated with this syndrome complex, and all these patients should be actually screened for associated abnormalities. They frequently cause complications, so therefore standalone treatment of asymptomatic patients may be justified in this setting. Contemporary embolization techniques are usually adequate for majority of these patients, and this treatment is the first line of treatment in most situations today. The risk of serial growth and also recanalization of treated patients mandates that a close follow-up of these patients should be maintained over time. Thank you so much for your attention.